We have to set that on table. Right here.
Hello, hello.
Awkward.
Guys all look so different without masks on. Okay, Sydney's losing it.
Oh, they have their cameras on.
So used to seeing everybody. Now I get to see without masks on. It's so gratifying. All right, it is 7 o'clock. We'll probably have some more people check in as time goes on. We got 11, no, 12 people, 13. Okay, folks are rolling in. We will go ahead and get started then. Once again, let me apologize for this format. I know this is not the favorite format of, well, all of you, but rules are rules. Let me say I had a lateral flow antigen test this morning. It was negative. So now we gotta wait for the PCR test because I have to have a negative PCR test before I am allowed on campus. So the test was started, well, the sample was taken, it was delivered to Garcia Labs. We'll see how long it takes them to get back to me. So will we be on Zoom on Wednesday? I have no idea. Depends when the test results come back in. We'll figure it out. So there we are. Okay, let's go ahead and start with a word of prayer. Father, thank you for sunshine, even though the breeze is kind of cold. We want to pray for my daughter that she gets well and stays well. And please help me to, one, not be sick, two, to keep from getting sick. And thank you, I was able to get the first vaccine Friday. Now, Lord, help us to learn and may this time go well, even though this is not an optimal medium. The Lord help us to use it and still be thankful for the chance to get an education. In Jesus' name we pray. Amen. Okay, did you all get the handouts I sent via email? Not so many dead trees this time, more just emails. All right, go ahead and take a look at the PowerPoint that I sent you entitled Atherosclerosis. That one. Oh, let me just say, if you guys have a question, unmute yourselves and ask a question. If you do the chat function, I won't see it. I get this little prompt on the top, and sometimes I see the prompt, most of the time I don't. So just unmute yourself and ask your question. And that I will hear you. Okay. So here we have a vessel, and we have endothelial cells here. These little gray dots are meant to be LDL. And these endothelial cells are sitting on some sort of matrix or cellular matrix, like this. Now, if you have high turbulence, if you have angiotensin II, or hypertension, or diabetes mellitus, or in fact, certain types of infectious diseases like syphilis or Lyme disease, you will damage these endothelial cells. They will lose their contact with the underlying extracellular matrix, and they'll do this. They will crease up like this, kind of like a piece of paper kind of doing this. So they crease up, they go down. They crease up, they go down, they crease up, they go down. When they do that, LDL can become deposited underneath the endothelial cells, and they can stick to that extracellular matrix. That extracellular matrix is pretty sticky. The LDL sticks there, and then the endothelial cell goes back down. Now, these endothelial cells behave as though they are a foot with a pebble in its shoe. So they start to make reactive oxygen species. By reactive oxygen species, we mean things like hydrogen peroxide, and it's hard to write with a mouse, and superoxide radicals, which are molecular oxygen with an extra charge, and things like that. These are going to oxidize the LDL, And so you get this oxidized LDL here. Oxidized LDL is a pro-inflammatory signal for these cells. So these cells will start to make chemokines. They will make the macrophage chemotactic protein 1, MCP1. These will summon macrophages. They also make interleukin 8. That's a pro-inflammatory molecule, also summons macrophages. Then they make these cell adhesion proteins. They make a toll receptor 2, which is a pro-inflammatory molecule. And then these three molecules are cell adhesion molecules. And these will help the macrophages stick to them. So VCAM stands for vascular cell adhesion molecule 1. ICAM stands for intracellular cell adhesion molecule 1. And then P-selectin is yet another cell adhesion molecule. So these three are all cell adhesion molecules. These are secreted here. That is cell surface, but it's pro-inflammatory. These are cell adhesion molecules. So the endothelial cells make their active oxygen species, and they upregulate these molecules here. So they attract macrophages, which are shown here. These are macrophages. The macrophages come and they adhere to the endothelial cells. Then, once they adhere, they're going to do something called rolling, where they flatten and roll along the surface of the endothelial cell. Then they're going to dive right in between these endothelial cells. When they get underneath the endothelial cells, they're going to gobble up the oxidized LDL. So these get recruited to the endothelium. They get changed. They roll, attach, roll, and then go beneath the endothelium. And now they gobble up the LDL, which you can see here. These cells, macrophages, now become transformed into foam cells. Foam cells. So foam cells, think of soap suds. Because in a microscope, that's kind of what they look like. They look like cells full of Mr. Bubble. You guys are probably way too young to remember Mr. Bubble. Scrubbing bubbles. They look like cells full of soap suds. And this is called fatty streak formation. And if you look at this in a cross section, it looks like the endothelial cells just have this fatty streak beneath them. And it frankly looks kind of innocuous, but that's what it looks like. Okay. Are there any questions so far? No? On we go then. Now the foam cells are going to secrete a gaggle of growth factors. There's 4 of them. So there's transforming growth factor beta, or TGF beta. There's platelet-derived growth factor, or PDGF. There's fibroblast growth factor, otherwise known as FGF. And then there's heparin binding epidermal growth factor. So these four growth factors, TGF beta, PDGF, FGF, HBEGF, they're going to signal to these smooth muscle cells here that line the vessel. So from AMP, maybe you'll remember, let's review a little bit here. So your vessel has a endothelial layer, and that is called the intima, And then outside the intima, you have a layer of smooth muscle. And that smooth muscle is called the media. So the tunica intima, the tunica media, and then outside the tunica media, you have the either tunica externa, also called the tunica adventitia, which is mainly connective tissue. And one of the ways you tell an artery from a vein is that the tunica media is a lot thicker in the artery than it is in the vein. So these cells here of the tunica media, they are going to proliferate and migrate in response to these growth factors. They proliferate and they migrate around the foam cells, and they form a cap like that. And some of these smooth muscle cells can actually take up LDL and themselves can become foam cells too. So the foam cell aggregate can also grow. Notice that the vessel is starting to become occluded. Then in response to TGF beta, the smooth muscle cells make collagen, and the collagen makes a fibrous cap, I had an iPad with a pen, I could do this a lot faster instead of doing it with a mouse. Fibrous cap. And that collagen is going to stabilize this structure. Now, some atheromas, these are called atheromas in this case, atheromas. And the material in there is called plaque. Now that foam cell is going to secrete matrix metalloproteases. That should be an I. Matrix metalloproteases. Those matrix metalloproteases will damage the overlying endothelial cells. They expose the collagen, and the collagen are highly thrombogenic. In other words, they induce coagulation, and you form a clot. The clot occludes the vessel, and you get an infarction. So if this occurs in a coronary artery, that's a myocardial infarction. Also, if these form in place, they're called a thrombus. If they break off, they're called an embolism. They can lodge in a cerebral vessel. If they do, they will form a transischemic attack, which we otherwise known as a stroke. If they lodge in the pulmonary circulation, you will get a pulmonary embolism. Both of these are life-threatening, as is a myocardial infarction. So this essentially is the end game of these plaques. Many times the plaque will stay here and will be stable. It'll stay that way and none's the wiser. But they can also rupture, and if they rupture, you'll get a clot. And this essentially, okay, pen, where'd you go? So this right here is a clot. And that, folks, is the pathophysiology of atherosclerosis. How do you prevent this from happening? You prevent this from happening by decreasing the amount of LDL in circulation. So by decreasing the amount of LDL, you lower LDL, you decrease the occurrence of this. That's what your drug therapy is going to try and do, is it's going to try to lower this pup here. LDL is what causes atherosclerosis. That's why LDL gets called bad cholesterol, because it's the atherogenic particle, plasma lipoprotein particle. Now, when you get to this point, is it reversible? Yes, it's very clear that HDL can extract cholesterol from this type of lesion. That's why HDL is protective. That's why it's called, quote unquote, good cholesterol, a term which I detest, but it makes the point, I think, well, in that it's a protective particle. Okay. All
Dr.
right.
Baratovich,
Yes, go ahead, Abby.
what was the MIA? Like, what did that stand for on the last slide?
MIA.
Or TIA? I
Oh,
forget.
TIA, transischemic attack.
Okay, thank you.
Transischemic attack, that's translation, that's a stroke. That's your speaking medicalese for a stroke. Because it's ischemia. Ischemia. Abby, what does ischemia mean?
I don't remember.
Anyone remember what ischemia means?
Is it lack of oxygen?
That's exactly what it is.
Okay.
Anytime a tissue, an organ is deprived of oxygen, that tissue or organ is undergoing ischemia. So transischemic attack refers to ischemia of the brain. Very dangerous situation, obviously. And many times with TIAs, you don't get thrombuses that form in situ. They can, but most of the time it's due to emboli that have formed someplace else, most commonly in the legs. And what do we call those when they form in the legs?
A DVT.
A DVT. Very good. A deep vein thrombosis. Everybody say that to yourself out loud right now. Deep vein thrombosis. Remember that. This is why you get patients up after surgery. This is why you turn patients. This is why even if they can't get up, you take their legs and you move them back and forth. That movement is going to prevent pooling of the blood in the venous system of the legs. When blood pools, you increase the risk of a deep vein thrombosis. Does that make sense? Okay,
Yeah.
just nod your head. If not, ask your questions, go, because we're going to go to the drug therapy now. Okay. Okay, I'm going to show you a chart that I didn't give out to you, but it's one you've probably seen before. So I'm going to go to my little overhead camera here. Okay. So your total cholesterol, what you want to see is below 200, and that's millimoles per liter, or it's milligrams per deciliter. That's usually the more common unit is mgdl, the milligrams per deciliter. That's the one you usually use. So below 200 is what you want to see. If it's above 200, if it's 240 is usually the, dude, that's too high. We need to do something about it. If you're 200 to 239, you're kind of in the, if this is green light, this is red light, that's yellow light, essentially. So this is, you have a talk with your patient. Let's get that down. Let's do what we can to get that down. LDL, you want to see it at 100 or below. Now, for a young person, usually between 100 and 129 is acceptable. It's usually not, if you guys, for example, went to the doctor, got a lipid panel, your LDL was 124, your doctor probably wouldn't think two thoughts about it because you're young and active and healthy. Now, if you were diabetic, it'd be another story. If you're diabetic, your doctor would say, it's got to be here. No ifs, no ifs, ands, ors, or buts. Has to be here. If you're above 130, now you're in that okay, let's get that down. If you're at 190 or above, it's, dude, that's too high. That's right. And if you're above 160, that's too high. This is 190 is dangerously high. So essentially 100 is desirable, but what you have to play with is between 100 and 129. Now, in April, I'm going to celebrate my 60th birthday. So my doctor now looks at me and says, Mike, we want you to be at 100. No more of this business. We want you here. Now, if it's 101, is he going to complain? No. If it's 124, he's going to complain. So you get more leeway than I do. HDL. HDL, there's really not a number that's too high, but 40 is the cutoff. If it's below 40, that's too low. That's too low. Triglycerides. Triglycerides are very influenced by diet. These are influenced by diet, but they're also heavily influenced by genetics. Triglycerides are really influenced by diet. So if you have someone with numbers and they seem a little high, but it's running high in their family, traditionally, check their triglycerides to see what their diet says. So triglycerides, 150 is the cutoff. Below 150 is good. 200 is kind of the 150 to 200 is the yellow light, and above 200 is high. If you're in the 500 range, that's just dangerously high. Dangerously high. So the point is to do something before it gets to very high. Do something before it gets here, do something before. it gets here. Now, what are the sort of complicating factors that'll make you say, we want it lower than this, we want it lower than this? And these are the complicating factors. First of all, if you have coronary artery disease or some sort of equivalence, and if you have symptoms of coronary artery disease and the arteries that are most likely to experience coronary artery disease in descending order are, first of all, the abdominal aorta. That's the first one. Then the coronary artery. Well, arteries, any of them, not just one particular one. And then the carotid. Either the left or the right or both. This one's at the biggest risk, then this one, then this one. So if any of these arteries show any sort of symptoms, or if you have some sort of peripheral arterial disease, you're at high risk. You need to be essentially in the lowest end of these numbers, and you need to have high numbers here. If you're diabetic, someone comes in and they're diabetic and say they have 120, in your head, add 30 to those numbers. So they're up here, they need to be treated. They need to be below here. Cigarette smoking, big, big factor. If someone's is a cigarette smoker, then they're essentially at a higher risk for coronary artery disease, largely because cigarette smoking increases inflammation inside blood vessels. Hypertension at or above 140/90. If they're on an antihypertensive drug, if their hypertension is well controlled, they're consistently at normal, it's not such a big deal. My doctor told me that according to the American Association of Family Practitioners, it depends on your age. So if for him, it's 50. If you're starting to get in your late 50s, you're on an antihypertensive drug, usually he's going to want you to be essentially in these lower ends. If you have low HDL, that's a biggie as well. Some people just have low HDL. Family history of premature coronary artery disease, also age, 45 in men, 55 in women. Two major risk factors are present without coronary artery disease, so on and so forth. These are essentially risk factors that will say these need to be lower. All right, so I sent you these particular handouts. Let's go ahead and look at these now, if you can pull those out for me. Here's how statins work. Statins interfere with cholesterol synthesis. They inhibit the most important step in cholesterol synthesis. That's the synthesis of this compound called mevalonate. Mevalonate. The enzyme is HMG-CoA reductase. Statins directly inhibit that enzyme. Therefore, they decrease endogenous cholesterol synthesis. That's the first thing they do. The first thing they do. Then, because the cell senses, oh, gee, I don't have any cholesterol. What do I need to do? I need to upregulate the synthesis of the LDL receptor. This is a knock-on effect of inhibiting endogenous cholesterol synthesis. So you get increased expression of the LDL receptor gene. That means you get increased clearance of LDL from the circulation. That increased uptake of LDL by hepatocytes is going to decrease VLDL production by the liver. So again, decreased endogenous cholesterol synthesis, increased expression of LDL, consequent increased clearance of LDL from the blood, and consequent decreased VLDL synthesis by the hepatocytes. Right? That clear? Okay, let's talk about statins. Your statins all end in vastatin. So atorvastatin, fluvastatin, lovastatin, pravastatin, rosuvastatin, simvastatin, and so on and so forth. Definitely the most heavily used statin is atorvastatin. It's extremely well tolerated. The reason this drug is used so much, it is effective at a lot of different concentrations. It's effective from 10 to 80 milligrams. Oh, and by the way, statins are given orally. I really can't think of a statin that's given parenterally. They're PO. So this is definitely the most heavily used statin, atorvastatin, for definite sure. The first statin ever developed was lovastatin. It was called Mevacor originally. And then the next statin to come out was simvastatin, which is even more powerful a statin than lovastatin. This is also effective over a very wide range of concentrations. This can lower your statin, your LDL by 30 to 40%. Higher concentrations can lower it even up to 45%. Very effective drug. Pravastatin is also available and is effective over several different concentrations. Lovastatin now comes in an extended release that's better tolerated. Fluvastatin is probably the newest of the statins. It's also the least potent. So this is good if you don't need that powerful a statin. Rosuvastatin is the most potent of the statins. This is the one that Donald Trump was on. He released his numbers to the press, even though he's on quite a bit of rosuvastatin, his LDL was still pretty high. That's what happens when you feast on a diet of fast food. But this will drop your LDL up to 50 to 60%. High dose atorvastatin will drop it by 55%. Very, very effective drugs. Let's talk a bit about the side effects of statins. So your statins on the average are very well tolerated. Reports range from usually GI disturbance. I will say in most of the reports, this is transient. So this may happen at first, but it's usually transient, goes away usually after a week. Does everyone know about what I mean by transient? Good. All right. So this goes away. Some people report headaches. Those are also transient. Those tend to go away. Now, let me also tell you about statins. If you don't tolerate one statin, very often you can switch people to another statin that they will tolerate. That's one of the beauties of these drugs. The biggest issue with statins is usually muscle aches. Muscle aches and myositis. Very rarely, some people get central nervous system effects. The biggest one being depression, but that's rare. And then some people show liver damage. That's also rare. The biggest issue with statins that you need to worry about is rhabdomyolysis. This happens in 1 to 2% of cases. So with rhabdomyolysis, you're going to have lots of muscle pain. Typically, if you feel the muscle, it'll feel like it has knots in it. You'll start to release muscle assemblages into the blood. These will get stuck in the kidney. You'll end up with renal failure. So this is serious. You'll see certain proteins in the muscle. The big one is going to be a creatine kinase. That's your big marker, muscle, skeletal muscle creatine kinase. And then the urine will turn really dark. If you see that triad, crippling muscle pain, very dark urine, also back pain, and you order a lab, there's creatine kinase in the blood, you get them off that statin as fast as you can. And you may need to start doing something to support the kidneys. Again, this does not occur often, but it does occur. Some drug interaction things to consider with statins.
Dr. Radovich,
Yeah,
with the rhabdomyolysis, if you take them off that statin, can you still put them on another one?
yes, you can, but you have to do that with caution.
Okay, thank you.
You can switch statins. That has been shown to work. Now, lovastatin and simvastatin are both cytochrome P450-3A4 inhibitors. So if you use these drugs with cytochrome P450-3A4 inhibitors, you have an increased risk for rhabdomyolysis. Atorvastatin is a 3A4 substrate. It is not a 3A4 inhibitor. But if you use it with 3A4 inhibitors like grapefruit juice or erythromycin or drugs like that, you do increase the risk of rhabdomyolysis. Fluvastatin is metabolized primarily by cytochrome P450-2C9. 2C9. So if you use inhibitors of 2C9, then you can get rhabdomyolysis risk with fluvastatin. Pravastatin and rosuvastatin. And there is a newer drug called pitavastatin. Pitavastatin, these are metabolized by phase 2 reactions. They're not metabolized by CYPs. So pravastatin, rosuvastatin, pitavastatin, those you don't have to worry about cytochrome P450 interactions. So those are the statins. Are there any questions about statins before we move on to other drugs?
Dr. Bradovich, which one
Yes.
was the cytochrome P450 inhibitors again?
Say again?
Which one were which drugs were the cytochrome P450 inhibitors again?
Lovastatin and simvastatin. Lovastatin and simvastatin. Bile acid sequestrants bind bile acids in the GI tract, and then they prevent the bile acids from being reabsorbed. So because bile acids are a dumping ground for cholesterol that comes back to the liver, these essentially deplete your body of bile acids. So they essentially are going to decrease the amount of cholesterol that gets redelivered back to the hepatocytes. These are not systemically absorbed. Therefore, they have no systemic side effects. All their side effects are GI. So there's 3 drugs here. They're all taken orally. You take them with food: cholestyramine, cholestyramine, and cholestyramine. So these drugs will cause constipation, constipation is pretty common. They can cause GI distress, although this one, cholestyramine, is the one that causes the least GI distress. And in some people, at a low percentage, you increase your risk of gallstones with these drugs. When do you use these drugs? You use these drugs in people who can't tolerate statins. There aren't very many people like that, but they do exist. Because of that, they are used. You don't take these with lipid-soluble drugs. They'll prevent the absorption of lipid-soluble drugs. You also don't take them with fat-soluble vitamins. If you have fat-soluble vitamins, you take those 4 hours after you've taken these or 2 hours before. And those are your bile acid sequestrants. And I think, yeah, oops. This is the picture that I used. I gave you to show you how these work. They work in the GI tract. So because of that, they're depriving the liver of cholesterol. So they increase the synthesis of the LDL receptor, they increase LDL clearance, and these go out with the wash, essentially. Questions about the bile acid resins, binding resins? No? Let's then talk about this drug, Ezetimibe. Ezetimibe. This is a drug that prevents cholesterol absorption in the small intestine. Cholesterol is absorbed by the Niemann-Pick type C like protein 1, or NPC1L1, Niemann-Pick-1 like 1 protein. This is a cholesterol transporter that's found in the brush border of your small intestinal cells. Ezetimibe directly inhibits that absorption protein. You don't absorb cholesterol. Therefore, you reduce the number of chylomicrons. You reduce cholesterol uptake by the liver. Therefore, you decrease VLDL, you decrease LDL, and you're going to increase the LDL receptor synthesis, increase LDL clearance. This will only work on dietary cholesterol. You can combine this with a statin. This drug is very well tolerated. This drug was marketed as Zetia. It's in generic now. This will drop your LDL in combination with a statin about 20%-ish. Biggest drug interaction with this drug is warfarin. It increases the anticoagulant effect of warfarin. Beyond that, it's pretty well tolerated. Oh, one thing I forgot to mention about statins. Statins are contraindicated in pregnancy. Definitive developmental abnormalities have been established in mothers who take statins and are pregnant. So they're completely contraindicated during pregnancy. Okay. Let's do the fibrates first, then let's take a break. So fibrates, once again, are used for people who can't tolerate statins. Fibrates are used mainly for people who have high triglycerides. Fibrates work by activating a transcription factor called PPAR alpha. What's PPAR alpha? PPAR alpha is a transcription factor that activates genes involved with the breakdown of fat. As you break down fat, you also break down other things, cholesterol and what have you. So you have increased fat breakdown, you have increased peripheral VLDL clearance, you have less chance, therefore, for the VLDL to become LDL, you have decreased plasma triglycerides, you have very slight increases in HDL, and that's what fibrates are, that's how they work. Of the fibrates, you have fenofibrate and gemfibrozil. Fenofibrate and gemfibrozil. Gemfibrozil is the only fibrate with a demonstrated beneficial effect on cardiovascular outcomes. You do not use this with statins. If you use it with statins, you increase the risk of myopathy. There was another drug called fenofibric acid, but it's no longer FDA approved. This is really the only one with evidence that has clinical benefit of work, even though in some cases this one works better. Common side effects of these are gastrointestinal disturbance, gallstones, and hepatitis has been reported. as has myostitis. These are contraindicated in people with either liver or gallbladder disease. And you have to be careful in people with renal disease. You have to adjust for renal function with these. These may also potentiate the effect of warfarin. Do not use these in combination with cyclosporin, which is an anti-rejection disease. Those are the fibrates. All right. Let's take our break. Let's take 5 minutes. If you have any questions, please unmute yourself and ask me. I will stay here. And so starting 5 minutes, we'll have our break starting now. So get up, walk around, get a drink of water, whatever.
Dr. B, could you
Yes, Grace.
repeat the side effects of the fibrates, please?
Sure. GI disturbance is very common. Tends to diminish, but never goes away really. And then there have been other reports of gallstones, inflammation of the liver, and inflammation of muscles, so myositis, hepatitis. Those aren't super common, but they're not unheard of. And then they're contraindicated in people with either liver or gallbladder disease. And because these drugs are renally excreted, you have to make sure you adjust the dose for people's renal function.
Okay, thank you.
These are also contraindicated during pregnancy as well.
Where do you want us to upload our, or like embed our link for our pharmacist interview with the pharmacist video? I didn't see a spot for it on Blackboard.
The directions don't tell you where to put
It
it?
said put it in, I believe it said under course materials, and then embed it on some like thing, but I couldn't find it under there.
Oh, crumbs. Allison, so you take the link, so number 4, after you put it on the YouTube page, you do see where I am here? Can you see my screen?
Yeah.
So you open the video, click the share button, copy the embed code. So you you copy the embed code
Mm-hmm.
right here. And then you essentially open the HTML code view icon from the toolbar that's shown here in the content editor. You embed the code, click update, and then click submit. And then that should do it. Haley Donnelly submitted hers doing that. And I was able to say, when that happens, needs grading, it comes over here and then I get a prompt that says, oh dear, I've got some grading to do. I need to catch up on that. Sorry, gang, I'm behind. I get a prompt over here that tells me to grade it. And that's essentially what happens. If you're looking for a link essentially to embed it, this essentially is how you do it right there. And I'll see it. I will see it.
So I have to, okay. I found it. Thank you.
Okay, it's pretty easy.
Yeah.
And if you have trouble, ask Haley, because Haley's
Okay.
the one who did it, and her video looked without sounding too wishy-washy. Her video was stellar.
Perfect.
Had great quality, great sound quality. The lighting was really good.
Okay.
The phones these days, the cameras on those phones are just amazing.
Yeah.
So, the camera technology has come so far. So if you run into issues, seriously ask Haley, because hers worked and it worked quite well.
Perfect. Thank you.
Allison, one of the best things you might do is show your video to someone else, just because they might see things in the video you don't see. That's been my, I hate watching myself on camera. So after I watch it, if it looks okay, having somebody else look at it, just make sure they see things that you might not have seen. Just
Okay.
that way you'd
Thank
be happier with it.
Yeah.
Okay. Break is over with. It's time to resume. Before I resume, I'm going to tank up here. I'd much rather be with you guys in the classroom, but complaining is not going to help. All right, we talked about fibrates, talked about statins, talked about bile, resin sequestrants. Now let's talk about the PCSK9 inhibitors. What are PCSK9 inhibitors? Here's how they work. So here's the LDL receptor. When the LDL receptor is outside, it may get bound by a protein called PCSK9. When PCSK9 binds to the LDL receptor, and this binds LDL, it goes to the endosome and the receptor gets degraded with the LDL particle. PCSK9 inhibitors bind to PCSK9, like you see down here. They're antibodies. They bind PCSK9. They therefore prevent the LDL receptor from being degraded. They therefore lengthen the half-life of the LDL receptor. And these are used for people who have a genetic condition called familial hypercholesterolemia. Familial hypercholesterolemia. This is a genetic condition that prevents people from properly taking up LDL and disposing of it. They have a mutation that affects the function of either the LDL receptor or some other part of the machinery that engulfs it or degrades it or whatever. People with this condition have very high levels of serum LDL. And they tend to experience the effects of hypercholesterolemia in their 20s, and they need extensive statin treatment. Well, if you combine statin treatment with these drugs, now you start to give them, these will give a 50 to 70% LDL reduction, even as a monotherapy. And then if you combine that with high dose statins, you can now get their LDL into the normal range. So there are 2 drugs that have been approved by the FDA. Again, these are monoclonal antibodies. So there's alirocumab, goes by the market name of Pravolent. Remember, because these are monoclonal antibodies, they have to be given parenterally. These are given in an injector pen, and the patient injects him or herself sub-Q. Sub-Q. So alirocumab, and then evolocumab, or Repatha. Alirocumab, evolocumab. Very, very effective drugs when it comes to reducing LDL. These drugs are very well tolerated. Usually what you get are muscle aches, rash, maybe some sort of urticaria, and mild injection site reactions. That's pretty much it. These are pretty well tolerated. So these are for people with that familial hypercholesterolemia. Very good. Are there any questions about treating hypercholesterolemia? Okay. Quick quiz. Patient comes in, they're on statins. What's the first question you're going to ask them? You'll have to unmute yourself to give the answer right away.
Could you ask if they're pregnant?
Yeah, that's a good question. Suppose they're older, already had their kids, or if it's a dude. And I'm not yet at that point where I can say that men can get pregnant. I don't think I ever will be. So what's the other first question you ask?
Maybe what side effects you have?
Like?
If they've had any muscle pain.
There you go. Good job, Sarah. Muscle pain. Muscle pain. And then how severe is it? And then do they have any back pain? And do you have really dark urine or something like that? That triad, remember, muscle pain, back pain, dark urine. That's your big thing is rhabdomyolysis. Okay, now, You should have received a handout with the angina classifications on it. So that handout should look like this. Does that look like something I sent to you? Yes? So get that out and make sure that's at the ready. So angina pectoris. Angina pectoris is chest pain. It is substernal. It may radiate. And if it radiates, it usually rates up to the neck. It might even radiate to the left arm and shoulder. Thing about angina pectoris, they usually get this pain upon exertion. And it goes away with rest. Let's say rest treats it. That's the thing about angina. Goes away with rest. It's associated with exertion. Rest is going to treat it. All right, let's talk a little bit about the circulation around the heart. Very quick review of A&P from last year. Your arteries essentially come from the sinus of Valsalva from the aortic root. So as the aorta emerges from the left ventricle, you have a left coronary artery and a right coronary artery. The left coronary artery swings around the heart. That's the circumflex artery. And then there's a branch that covers the front of the left ventricle. That's the left anterior descending artery, otherwise known as the LAD. The LAD, left anterior descending artery. The right coronary artery swings down like this. And it has multiple branches. The first one is called the marginal artery. The marginal artery, which supplies the right ventricular muscle. This is going to head essentially this way. It follows the coronary sulcus that you have between the atria and the ventricle. This is then going to swing around to the other side of the heart. This is the front. This is the back. The right coronary artery is then going to become the posterior interventricular artery. The posterior interventricular artery swings around. Posterior interventricular artery, just like that. Your circumflex swings around like this. And then there's usually also a circumflex branch as well that will come down here and will provide the back of the left ventricle as well. Those are the arteries. The right and left, and then the circumflex, the LAD, the posterior branch of the circumflex, the right and the marginal, and then the posterior interventricular. Oh, sorry, I forgot to, you also have something called the posterior descending, PDA, posterior descending artery as well. Those are your main arteries. If these arteries get plugged by means of atherosclerosis, you have a mismatch between cardiac muscular oxygen demand and cardiac muscular oxygen delivery. So when demand exceeds delivery, you now have cardiac muscular ischemia. Cardiac muscular ischemia, that's now going to increase concentrations of adenosine. It's going to increase concentrations of bradykinin. That's going, and other small molecules, these are the main ones, that's going to cause pain. This is not pain like, oh, you did too many declines in the gym. This is, oh, I have to grab onto something. Holy Hannah, this hurts. That's called angina pectoris. And when someone has this pain, if they're on an ECG, you may see ST wave depression. May see ST wave depression, depends how bad the angina is. You see angina when the coronary arteries are at least 70% occluded. So when these vessels get occluded, at least 70%, you'll get angina.
Dr. B,
Yes.
what did you say caused the ischemia? Like the mismatch between cardiomuscular O2 demand and
Right. So the coronary arteries go from this because of atherosclerosis. Now they're like this. Or maybe even like this. So is how much oxygen is that going to deliver relative to this? This is a cross section of a vessel because this is loaded with plaque and all that stuff here. You see how the occlusion of the vessel prevents you from delivering oxygen?
yes.
When the vessel is at least 70% occluded, you will start to get angina symptoms.
Okay.
That's why you get this mismatch between oxygen demand and oxygen delivery.
Okay, that makes sense.
Okay. All right. Now, angina comes in several classifications. This is a so-called New York Academy, New York Heart Academy classifications. So class 1 means you get angina with strenuous work, strenuous exercise. You're doing you're running, you're sprinting, you're running long distances uphill, you're lifting heavy weights, you're shoveling your walks and you're really going for it and you're huffing and puffing like mad. When you get pain under those conditions, that's class 1 angina. When you have angina under more moderate exertion, moderate meaning 2 flights of stairs, walking a block or 2 blocks uphill, then that is class 2 angina. Class 3 is angina with even moderate, mild exertion, walking 1 to 2 blocks at normal pace, climbing 1 flight of stairs at normal pace. That would be class 3. Now, if someone, say, gets angina, if they walk up 7 flights of stairs, that's not class 3 angina. Class 3 angina means they'll get angina after climbing 1 flight of stairs. Class 4 angina is an angina at any level of physical exertion. So keep in mind, this type of angina is predictable. The patient can predict based on their exertion when they're going to get angina. This is called stable angina. And it's the most common. Any questions about this classification? Very good. Let's go to the medications that you use for angina. Your staple medications are your organic nitrates. And the mainstay is nitroglycerin. So nitroglycerin, this is not nitroglycerin that you have in dynamite that goes boom. The nitroglycerin in tablets is of a form that will not explode. You cannot have nitroglycerin tablets in someone's car and all of a sudden they'll explode. That's a different, I know in detective novels and some detective shows, they have that happening and it's bunk. This is of a different preparation. Nitroglycerin comes in several different preparations. So it comes, first of all, what does nitroglycerin do? It increases the amount of nitric oxide. What does nitric oxide do? Nitric oxide will induce the synthesis of cyclic GMP inside cells. So this induces this enzyme called guanylyl cyclase that takes GTP and converts it to cyclic GMP. Cyclic GMP causes vasodilation. So you're dilating those coronary arteries. So now your oxygen delivery goes up. So nitrates decrease angina symptoms. They decrease angina symptoms. They also work very quickly. Nitroglycerin is your mainstay. Nitroglycerin comes, the most popular is a sublingual tablet. It's usually 0.4 mg. When someone uses nitroglycerin, no cotton. Cotton will break it down. They also have to keep the tablets in the dark. The bottle will usually be a dark bottle. They also have to keep it in a cool place. Heat is deleterious to the nitroglycerin. It also comes as a patch, so a dermal patch. If you wear this usually, you'll wear it usually for about 12 hours. Then you have to have it off for another 12 hours.
Dr. Moravich,
Yeah,
when you say no cotton, do you mean like the cotton balls that they put in the med containers?
yeah, so that the pills don't, when you pick them up, the pills don't go jingle, jingle, jingle and get shattered. You can't
Okay,
have
thank
cotton
you.
no cotton inside a nitroglycerin tablet bottle.
Okay, thank you.
So what pharmacists will do sometimes, they will put these in really small bottles and they will, there's a special bottle, it's plastic and it's dark. And you're supposed to keep it with you so you could take it whenever you need it. There's also a tablet. Tablet's not used that much. Isosorbide mono and dinitrate. The dinitrate's not used that much. The mononitrate is the one that's used the most. That is a much longer acting. So that is isosorbide mononitrate. That is longer acting. And that takes longer to act. That'll take about 1 to 2 hours to act. Sublingual nitroglycerin will start working in 3 to 5 minutes. You guys will see. Come on, you get in focus. You guys will see this a lot in your practice. Nitroglycerin is used a whole lot. Now, are there any other drugs that decrease oxygen demand of the myocardium? Think hard. How about beta blockers? Beta blockers decrease heart rate. They decrease cardiac output, therefore they decrease myocardial oxygen demand. Can they be combined with nitrates? You bet your life they can. So these are also used to treat angina. Other drugs that can be used are calcium channel blockers. In particular, verapamil or diltiazem. If your patient can't tolerate beta blockers, these are also very good. These can also be combined with nitrates. Beta blockers cannot be combined with verapamil, but you can combine beta blockers with DNPs. They will dilate your coronary arteries. You combine these with beta blockers, you'll cause a heart block. but these can be combined with beta blockers. And that is a good treatment for chronic angina as well. So let me show you a treatment algorithm for angina. Oh, for pity's sake. Come on. There we go. Okay, so if someone has type 1 angina, then usually an aspirin is a good idea. That will prevent platelets from causing a clot, and then nitroglycerin, PRN as needed. Once you're at type 2, usually, now you're going to add a beta blocker, or you may want to add a calcium channel blocker, either one with the aspirin. And then usually you'll have nitrates, usually PRN once again. When you get to type 3, use the aspirin now and a beta blocker with a calcium channel blocker, usually a DHP, with a long-acting nitrate, your isosorbate mononitrate. When they get to 4, now it's going to be the beta blocker and the calcium channel blocker with the aspirin and a long-acting nitrate. And then there are other features here. If somebody needs to have a stent put in, these are other issues for stents. But for our purposes here, this is what I want you to be able to think about for the treatment of angina. Very good. Any questions about the treatment of angina? No? Did I give you this handout?
No.
No? Would you guys like this handout?
Yes, please.
Okay, I will send this to you, or I'll put it on Blackboard. So watch for that email. Boy, I don't really have time to start anything else right now. So do you guys have any questions? Well, I'll tell you what I'll do. I'll just hang out. If you guys have any questions, you can hang and ask me a question. Next time on Wednesday, we're going to look at anticoagulants. So we'll look at antiplatelets, anticoagulants, their use in various things, and then we'll look at using them for PCI and in heart attack patients, and then we'll look at acute coronary syndrome and how you use them to treat people with acute coronary syndrome. So anticoagulants is on the menu for Wednesday. All right. And I will keep you posted as to my PCR test. When I know something, you'll know something. So maybe we'll be in class, maybe not. I don't know. We'll see. Okay. So I'll just hang here. If you have questions, don't forget your quiz is due before midnight. Please don't forget that. And yeah, I think that's it. Okay. All right, everyone, unless you have questions. Anything you want to ask, Audrey? No? Okay, then I will sign off.